Welcome to Chapter 6 for exercise programming for special populations. We'll see how this goes. Computer's been really bad today, so I apologize for any problems. All right, so cardiovascular conditions and disorders. So cardiovascular disease is a leading cause of death in the United States. Atherosclerosis is plaque in your arteries that basically squeezes off the blood supply eventually. Modifiable risk factors for the development of CVD include hypertension, lipid profile, exercise history, smoking, diabetes, and sedentary behavior all play huge parts into this. And non-modifiable risk factors would be age, sex, family history. Again, you look at the 4 down there, and you can really look at that as a small percentage that plays into whether or not you get it or how bad you get it and so on and so forth in comparison to your behaviors. Hypertension is a systolic blood pressure of 140 or higher and diastolic of 90 or higher, or both, confirmed on at least 2 separate occasions. Again, sometimes you're hypertensive, if you want to put it that way, blood pressure could be up for whatever reason, but doesn't mean that it's chronic, right? Which is what hypertension is. Elevated cardiac output or total peripheral resistance or both, and excess salt intake, salt sensitivity, chronic disease, kidney dysfunction contribute all to hypertension. But 90 to 95% of cases have unknown causes and are called primary hypertension. So medications, diuretics will reduce your fluid loads. Beta blockers, calcium channel blockers, and angiotensin II receptor blockers, angiotensin converting enzyme or ACE inhibitors can also affect your blood vessel tone. Individuals may be on multiple medications. Understanding of the side effects and effects on exercise are going to be necessary when you're working with these type of patients, right? Again, beta blockers, as we talked about before, will decrease your heart rate. So if you're trying to work them at different intensities, you can't really go by that. And you're going to have to go by basically how they feel they're working. Okay, you can't really go off their heart rate. And again, a lot of these can lead to hypotension. So like when you go from a sitting to standing or lying to standing type of things, just monitor them so that they don't kind of bottom out. Is you'll hear somebody say when they go into hypotension, they can get dizzy and pass out and things like that. Effects of exercise. Regular aerobic exercise improves VO2 max, improves cardiovascular efficiency, can cause decrease in systolic and diastolic blood pressure. So again, it's a very good way to combat hypertension. Regular resistance training can cause a decrease of 3 to 4 in both systolic and diastolic as well. So, a good combination of both would be recommended. And weight loss will also have positive effects on your blood pressure. So again, how do we figure out how to create a exercise plan? Again, you can look on table 6162, but you got to individualize it like we do everybody else. They need to have at least 30 minutes of aerobics exercise would be great. And RP at 12 or 13 if you're using that scale, or 40 to about 60% of their VO2, which again, you may not be able to do because of the medication. Again, if they're breathing, you can tell when somebody's working. You can kind of, you'll get used to the different, like they seem like they're doing about 50%, 60, again, talk test works fine. RP's okay. Blood pressure is reduced after exercise for up to 4 minutes. Multiple shorter bouts throughout the day may be more advantageous. Resistance training should occur 2 to 3 days a week at moderate intensity, 8 to 12 reps. Again, 60-80% of 1 rep max. You may not be able to 1 rep max them. Again, just, like if you're, if they can only do about 8 to 12 reps of something, that's pretty much what that is, So anything that can do 8 to 12 times, that's basically that same rep max range, okay? Higher volume circuit workouts can be appropriate. If their blood pressure exceeds 220 or 105 systolic and diastolic respectively, then you need to stop exercise. Peripheral artery disease, narrowing of non-cardiac arteries that result in reduction of blood flow. Hallmark of PAD is intermittent claudations, which is pain in the legs in conjunction with physical activity that occurs due to insufficient blood flow. Again, claudation will be relieved with rest, like CAD, PAD is the result of plaque buildup in peripheral arteries versus cardiac arteries, and has the same risk factors. Again, medications, blood thinners, antiplatelet, vasoactive agents, statins to reduce cholesterol. Medications for hypertension are the most common prescribed medications. Other disease states are also likely, and medications for those need to be considered as well. And most medications have little or no effect on exercise except what we've talked about. Again, that's the big thing you got to understand. When you don't take care of your body, you know, like some people think, okay, well, if I don't exercise and eat whatever, I'll just get fat. Okay, that's true. But then on top of that, you don't think about, okay, you know, like, well, how bad is this in consideration of my percentage chance of getting things like type 2 diabetes, heart conditions, stroke, cancers, and you know, I mean, that's the thing. And then again, once you get to a certain point, you have multiple problems, you're on multiple medications for all these multiple problems, and they're telling you, okay, well, what's a big thing I need to be doing to help myself besides medication? You need to be doing the stuff you should have been doing before to reduce the risk that you ever would have got those in the first place. But now it's much harder because one, you've got weight to lose, which is just harder. Your body is not conditioned, so it's, you know, physically and mentally it's harder. And two, you've got a lot of medications that now make it much more difficult to do. And when you exercise, it also puts you at acute risks because of all these things. You know, it's a mess. And if we get that into people's head, you know, I mean, we can make a way better difference if we get to them before they get to these areas, right? And before they get to this state of being. Again, effects of exercise. Claudation will often dictate exercise intensity, preventing exercise at more than low to moderate levels. Improve cardiovascular efficiency. With training, clients will be able to increase the intensity at which claudation appears, which then increases the benefits of the exercise. Again, recommendations on 6.3, 6.4. Again, with these, you got to figure out where the symptoms appear based on the intensity. Create post-exercise ankle pressure, or establish the post-exercise ankle pressure. Get good baseline data, and identify the presence of their cardiovascular disease. Walking is recommended for the greater use of the gastrocnemius muscles compared to other exercise modes. Intensity should be about 40 to 60%. Again, however you figure that out. Claudation pain levels of 3 to 4. Clients should then rest until pain subsides. Working until 30 minutes of exercise can be sustained without rest, right? So if they're doing like 5 minutes on and then they rest, 5 minutes on, you know, up till, you know, at some point you can do 10 minutes rest, 10 minutes rest, 10 minutes, you know, 15 rest, then 15, then try to get all the way through. Guidelines for resistance trainers similar to clients with coronary artery disease. Angina is basically just a pain in the chest. Again, it can come along with neck, jaw, arm, and back that occurs as a result of ischemia in the heart tissue. Angina is kind of a coverall for any chest pain. So it can be that they're having a heart attack. It can be that they're having a panic attack. It can be, you know, it's kind of, it covers a lot of things. All right. And usually result of narrowed coronary arteries from atherosclerotic plaque, can be brought on by physical exertion, stress, vasospasms. The level of exertion at which angina occurs is predictable and reproducible. An exercise professional can determine a suitable symptom-free exercise intensity. Again, medications, nitrates, calcium channel blockers, beta blockers are used to treat. So again, understand what the side effects and the reduction and what it's going to do to their body, and how you're going to have to determine their level of intensity based on that. Vasoactive drugs may cause dizziness, syncope, especially, you know, if they go from lying to standing and so on and so forth, like we talked about before. Regular exercise will result in increased efficiency of the heart, increased tolerable workload, increase in VO2 max, and also help reduce their body weight. And primary goal of exercise programming for a client with angina is to increase the amount of work that they can do before the ischemic threshold is reached. Again, following medical release, graded exercise tests, clients can undergo rhythmic large muscle group activities such as walking, jogging, or cycling from 4 to 7 days per week, 20 to 60 minutes, intermittent or continuous, at an intensity 10 to 15 beats per minute below the threshold for an angina. Resistance training can be 2 to 3 times a week, 40 to 60%. Again, basically you're looking at that like kind of 8 to 12 range, we're up to 15 just depending on what they can take. You don't want them to have chest pains. Longer than normal warm-up cool down are strongly recommended. And again, when you quote unquote shock a system, it can cause chest pain. So it's good to kind of ease into it and then not just stop once they're at a high intensity, but ease in and ease out. If symptoms appear, intensity just needs to be lowered at first. Nitrates may be taken if necessary. Symptoms persist, clients should immediately go to the ER. CHF, or chronic heart disease, is an inability of the heart to circulate adequate blood to meet all the metabolic demands. Can have systolic or diastolic origins, which is lower than normal contractility or failure of the left ventricle to properly contract or relax respectively. And people with CHF have reduced ejection fraction, which is Frank Starling mechanism. Stroke volume divided by end diastolic times 100, while those with diastolic failure will have normal ejection fraction but lower stroke volume. Coronary artery, chronic heart failure, again, may be a result of ischemic or myocardial infarction with significant tissue loss, or non-ischemic chronic hypertension. So it can either be like a big event, or it can just be chronic over time. Okay. Due to the reduced cardiac output and stroke volume, renin-angiotensin and sympathetic systems are activated to maintain blood pressure. Over time, this causes cardiac hypertrophy and continued stimulation of sympathetic response. Individuals with CHF experience severe exercise intolerance due to lactate accumulation at low exercise levels. Medications. Digoxin release or increases myocardial contractility to compensate for low stroke volumes. Beta blockers lower your heart rate. Diuretics reduce blood volume overload. ACE inhibitors reduce blood pressure and dilate blood vessels. Cardiac resynchronizing therapy or resynchronization therapy is used to synchronize the contractions of the ventricles, and all of these have major side effects. Exercise. Individuals with CHF will have much lower exercise capacity, greater shortness of breath and fatigue, and low workloads. Medications can improve the response, but also have effects on the heart rate, blood pressure, and impair the body's response to exercise. Intense exercise has shown some promise and may be safe for some individuals. Exercise testing should be done to ascertain lactate threshold, which can be used for accurate exercise prescription. Large muscle aerobic exercise should be done at 40 to 70%. VO2, 4 to 7 days a week, 20, 60 minutes per session if tolerated. If heart rate is not an accurate intensity measure, then RPE, or like I said, talk test, I think is a bit more accurate than that. Intensity interval training can be effective for those cleared to participate. Resistance training should be done 2 to 3 days a week using circuit training at 40 to 80% of the 1 rep max. Regular activity of any type and avoidance of long periods of inactivity should be encouraged pretty much for almost everybody. Myocardial infarction is basically just a heart attack, reduced or cessation of blood flow to heart tissue caused by a clot or blockage of coronary blood vessel. The severity of the heart attack depends in part on the amount of tissue that is damaged and the extent of collateral blood flow. Clots are more common, or most commonly, the result of the rupture of an atherosclerotic lesion and are related to risk factors including high blood pressure, hyperlipidemia, diabetes, and family history. Blood vessel bifurcations, branch points are common sites for plaque rupture because of higher fluid turbulence in those areas. Medications, again, you've got the beta blockers, the ACE inhibitors, Plavix, which thins your blood. Statins reduces blood cholesterol. Calcium channel blockers reduces afterload. They can improve exercise capacity, but they will also affect heart rate, blood pressure, and sometimes have some other side effects as well. Generally, same as healthy individuals, you want to increase VO2 max, increase cardiac efficiency. They need to lose weight. Response will be blunted depending on the amount of cardiac tissue damage. No exercise program should begin without medically supervised exercise test and period of supervised training, and they need to be cleared before they work with youth. Again, they got recommendations on 6, 9, 6, 10. Extended warm-ups, cool downs, again, are strongly recommended. Ease them in, ease them out. So that we don't have any complications with arrhythmias. Large muscle group aerobic activities on 3 or more days a week, an RP of 12 to 16 or 40 to 80% of VO2 for 20, 60 minutes. Resistance training 40, 80%. 1 rep max using 8 to 10 circuit training stations, again, is recommended. AFib is one of the most common arrhythmias that is increasing in prevalence. Electrical malfunction where the atria depolarizes very rapidly, up to 300 times per minute, resulting in an uncoordinated ventricular contraction. AFib is present in a number of conditions, including hypertension, coronary heart disease, valvular heart disease. Medications, Coumadin and Plavix prevent clot formations. Digoxin or digoxin, calcium antagonists, beta blockers control ventricular response, can improve exercise capacity. AFib reduces stroke volume, cardiac output by about 20%, and results in early fatigue. Exercise professionals should be aware of the effects of exercise on underlying conditions as well. Again, 611, 612 for all the recommendations. Exercise tolerance varies between individuals and again will depend on other comorbidities. Medically supervised graded exercise tests should be performed to determine proper intensity for their aerobic exercise. Again, they can do large muscle groups 4 to 7 days a week, RPE 13 to 16, 50 to 85% of their VO2 max peak, and use RPE because exercise heart rate is often an unreliable measure. Again, talk test is, we don't talk about it much in there because again, the talk test is subjective to how good the actual trainer is in determining it. All right. Again, recommendation 611, 612, resistance training should be moderate intense, 40 to 80%, 1 rep max, 2 to 3 days a week, doing 8 to 10 exercise circuit training format. An active lifestyle throughout the day should be encouraged. HIIT training may be appropriate for certain individuals. Pacemakers and defibrillators. So some people need a pacemaker or cardioverted defibrillator to keep their heart pumping on normal rhythms or to reset the heart back to normal rhythm. And so again, you've got to be aware of those. ICDs and pacemakers restore and optimize your heart rhythm. Underlying causes range from coronary artery disease, heart failure, MIs, sick sinus syndrome. Normal heart rhythms must be corrected to avoid further tissue or insufficient blood flow. In most cases, pacemaker ICD is itself the treatment, but they may be on other meds because of the other issues that may have led to that and other comorbidities. Exercise capacity should be improved with the use of the device, but it will be affected by the presence of other conditions. If the pacemaker is effective, the response to exercise training will be consistent with the expectations associated with underlying comorbidities. Again, look at 613, 614 for all recommendations. Medical clearance related comorbidities needs to be obtained as well. All these folks, I don't know why they just put it here. You need medical clearance on all of them. First few weeks of exercise should be at intensity that is not likely to alter integrity of recent implanted device. After that, exercise prescription will vary according to their comorbidities. except that heart rate should remain 10 to 15 below the rate that would trigger the device to fire. And again, the doc will put that on what you need to know. Symptoms that result from the device malfunction may be undue fatigue, syncope, dyspnea, dizziness, palpitations, tachycardia, or bradycardia. Valvular heart disease, incompetence of one or more heart valves resulting in reduced or inadequate blood flow, and increase in pressure in and size of all chambers in the heart. Valves can stenose, narrow, or harden, or fail to close completely, resulting in retrograde blood flow, so it backs up. Causes include rheumatic fever, congenital issues, infection, aging. Symptoms include dyspnea, fatigue, pain, and heart palpitations. Medications, AFib and CHD are common comorbidities, and the medications may be the same as what you'll see in those: ACE inhibitors, antiarrhythmics, antibiotics, diuretics, inotropes, beta blockers, anticoagulants, and they'll all have their different effects on exercise. And despite possible side effects, these medications generally improve exercise capacity, but valve replacement surgery may be necessary depending on the severity of their symptoms. VHD and comorbidity severity are basically going to make what type of exercise you do and how long and how intense dependent. Minimal symptoms, normal exercise and training are fine. Moderate symptoms, exercise response dependent on worse comorbidities, and severe symptoms, especially at rest, exercise possibly contraindicated. All right, for all recommendations, look at 615, 616. Medically supervised testing is recommended. For aerobic exercise, use large muscle group activities at 40 to 80% VO2 max peak, or RPE 12 to 16, 20 to 60 minutes a day on 4 or more days a week. Resistance training 30 to 50% 1 rep max on 1 to 2 days a week. Comorbidities may preclude all resistance training in individuals with symptomatic aortic or pulmonary stenosis, and longer warm up and cool downs again are recommended. All right, that's it for cardiovascular conditions and disorders. Again, it's kind of a quick one, not too intense. The book's got a lot more information on it. And again, whenever you have these type of clients, the big thing is to work with the doctors, look at all the medications, and the book's not going to give you all the playbook, because again, each person's different and you've got to treat them as individuals, as we do all our clients. All right, see you in the next chapter.